So I'm going to use part of the main preceptor curriculum for nurses and kind of go over what I see in precepting for techs. I thought this slide was really important because I think it's important that we start with what went well or didn't go well for you personally when you had a preceptor, and then what has or has not gone well for you as you precepted others. So I want you to take a minute and think about what it was like when you were fresh and new, and what were your biggest worries, what did your preceptor do, and what do you wish that they had done? So I remember I started as a nurse. Actually, let's go back to my first tech job. So my very first tech job, I was a CNA at, it was Camelot then, it's HHRC now. And I had a little bit of orientation, but not much. I was in nursing school. I'd taken the CNA program through MTC. And I just didn't know how to manage the whole group, and I didn't get much orientation, and we had to wear the back brace, and management was really difficult, and nobody really helped you figure it out. And I just remember being scared I was going to do something wrong. My preceptor helped me the most when they kind of demonstrated the role and how to, do the tasks like filling ice and, oh my gosh, these huge coolers that were on PVC pipes, cart things. And, just every, kind of task that we had to do. I transitioned from that job because they wanted me to continue working night shift every other weekend while I had class all day Monday. I eventually left that job, and at some point I went to work for VMRC, and my preceptor at VMRC was amazing. And I felt so supported and so clear on the expectations, and I feel like they knew what their job was, and I knew what I was supposed to do. And I've almost never even as a nurse, had such a thorough orientation as I did by that really great preceptor at VMRC. Trying to think, my next job, I worked home health for First Choice, and I had a really great preceptor there as well, because it was a very different role doing it in someone's home. And then I started as a nurse in the middle of a huge staffing crisis. Half of the staff had left on the unit, and my preceptor was also the charge nurse. And after about maybe 2 weeks, I had a full group of 6 patients, and she was charge at the desk. This is back with paper charts, when being charged meant you were putting in tons of orders for the doctors. It was a very different time. And while I felt supported to some extent, and she was super knowledgeable, I also felt like I missed things because I didn't have the background and the knowledge that I needed. So there were definitely some close calls with my patients just because I hadn't had that support. So take a second and think about what that looked like for you. So a preceptor is a teacher or someone who trains people how to do a job. Your role as a preceptor, I love this, it's really all this. You're the person that helps them feel at home on the unit. You're a socializer. You're a leader. So you're someone who we've deemed as a responsible, who does your job well. We want you role modeling appropriate behaviors, and you're teaching people how to do the skills. And I think that's super important, that we're kind of guiding them on best practices on how to do the skills. Just so you know, system orientation can sometimes stagger a little bit. Everybody does virtual orientation on Monday. On Tuesday, generally they come in and do badging. Depending on whether they start on an on week or an off week, they may have class on Wednesday, which means that we'll teach Foley insertion, sterile gloves, urine culture, phlebotomy, restraints, all that. And if not, they won't have that class until the following Wednesday. In between times, they're on the floor. So it really depends on whether they've started on a correct week or whether they've started on an off week as to whether or not they will have had class before you see them for the first time. There are definitely periods of shock as you start a new job. So there may be a period of time where you feel really good about yourself, like, okay, yeah, I can do this. And then you no longer have a preceptor and it's all you, and you hit a hard day or two, and then you're kind of in shock. and you're like, oh geez, I don't know that I can do this. And I definitely remember when that day hit. My shock phase hit when I was taking care of a group of patients and I didn't recognize how sick this 4-year-old was. And I walked back into a room to recheck him, and my nurse manager was there providing one-on-one care, and then within a few minutes or half an hour, we shipped the kid to OR for intubation and flew him out. And I had not picked up on how sick this kid was. I was just mortified. Recovery, you start realizing, okay, yeah, I do kind of know some of this, and it will be okay, and I'll get through this. And then resolution is where you really kind of start feeling like you can do this. We want to encourage you and your new hires to use the Sentara commitments, the safety habits to pay attention to detail, to communicate clearly, which means demonstrating and modeling effective handoffs, so giving report, repeating back with the walkies, asking questions, that you and they validate and verify, that we team up for safety by peer checking, making sure they're doing it right, and we're speaking up for safety. Sentara commitments, always keeping you safe, treating with dignity, respect, and compassion, listening and responding to you, keeping you informed and involved, and working together as a team to deliver quality care. We use the Get to Know You sheets. I have a slightly different one than this, but making sure that we're using these with new hires, just so we can get to know them a little bit better. Something you really should be asking, and hopefully your educator is helping you with, is, you know, what is the background and how much experience do they have? That's super important. So the next section I want to talk about is effective communication. So poor team communication can be linked to medical errors, turnover rates, and low morale. So if we're not communicating with people and we're not communicating effectively, then we can cause all sorts of issues. If low morale contributes to stress, burnout, poor job satisfaction, and poor quality of life. So we need to make sure that we're communicating effectively with our team and with our preceptees. And so that means we're talking well about what's going well and what isn't, and we're having those conversations in an appropriate manner. So when we're giving feedback, it's important that we prepare feedback. So we're really thinking about concrete examples, not using things like you always, you never. I noticed that when you left this room, you didn't set the bed alarm. So here's a safety habit that could help you. Something I use is I always stop at the door and I look, okay, is that green light shining? Or if it's not one of the new beds, have I gone back in and double checked that that bed alarm's on? So making that your practice to stop at the door and make sure that everything's safe might help you in this job. Focus on your tone. If you're really agitated or stressed out, take a few minutes before you provide that feedback. Making sure that it's facts and concrete, so not just like, oh, you never set a bed alarm ever. Well, they've set 2 bed alarms out of 5, so yes, their success rate isn't great, but you always, you never are not good feedback. Listen to what they have to say and then create a forward focus. So, moving forward, I'd like to see you pause at the door, or moving forward, let's take a second and let's all do this practice together. One feedback tool is called BEER. So BEER is behavior, effect, expectation, result. So going back to that bed alarm, I saw that you didn't set that bed alarm after we were done in that room. This has been linked to patients falling, which can cause all sorts of issues for that patient. It's the expectation that we double check that bed alarms are on, and then we're looking at that result. We want to see that that has impacted a result, or that the result would be that your patients are safer. So when we talk about role modeling, I want you to think about poor behaviors you've seen. And I think we've all seen it, whether it's someone who's been a little rough, or someone who has been argumentative, or whether it's not following the protocols. You've unsterilized yourself putting in the Foley, but you didn't stop to get a new pair of gloves. What kind of behaviors have you witnessed that would not be something you would want to emulate? Anytime I precept somebody, I always think about who do I want to turn them into, because these are the people I'm working with. So I'm going to work really hard to create in them or help grow them into the people that I would know that would have my back in a shift. And so that's always my mantra when I precept someone. Like, I want you to be able to do the job. And so I'd be like, oh, great. Oh, I'm so glad I'm working with you. You know those people. Like, I'm so glad that we're working together today, because I know we're going to have a great shift. We can handle anything together. These are the people. This is what we're trying to grow through precept. So let's talk about teaching skills. So these are the steps where a preceptor acts as a teacher. So they're teaching through figuring out how they learn, and we're going to talk a little bit more about learning preference and needs. We're planning activities to meet that needs, and this is something that you and your nursing professional development or educator can do together. So whether that's extra time doing phlebotomy sticks, whether that's another skill session, whatever that may be, what kind of activities do we need to meet that need? Whether it's, we haven't actually gotten to do a pre-op bath, so that person isn't in our group today, but maybe we can volunteer to do a pre-op bath or simulate it. We need to implement learning plans that include learning style preferences, and we're going to go over that. And then we've talked a little bit about feedback, but timely and effective feedback, and then evaluating and communicating progress. So for me, that happens in those biweekly meetings, so we're talking together as a group about where you are in the orientation, how that's going, and what do our next steps need to be. Because ultimately the goal of onboarding someone is to have them succeed in that role, and to be a great member of the team. So everybody learns a little bit differently, and I think one thing you have to understand about adult learners is that, one, it has something to do with generational differences that we'll talk about, but then everybody learns a little bit differently. And so you can see here in this picture all these different types of people and how they learn. So some people are really responsible for their own learning. They know what they need to learn, and they'll seek that out. Some people need to be able to connect things, like, okay, so I did this skill in class, and now I'm connecting it. Okay, this is how it's different, and this is how it's not. Some people need to be able to process and not be talked to as they're processing, so they can absorb it. Some people want to learn a skill and then practice it. Some people like to learn by themselves. They want to do just-in-time learning, video learning. Some people, once they've done something and they've mastered it, they don't want to do it again. As part of the practice, they want to learn the other skills that they need. Some people like connection. Every learner is a little different. And then when you get into generational differences, and this is super important, every age group typically learns a little bit differently. So people that were born in the 40s to the 60s typically like more classroom, they like paper manuals, they like tip sheets, they don't really want it in video, they don't really want an email, they really don't like computer-based modules, although that's just the reality. They struggle more with RQI. So these people, technology is not always their friend. Gen X, I'm barely a Gen X. They like teach back, they like role play, they like videos, they tend to be a little bit more computer savvy. Millennials really like interactive apps, they like websites, they like just-in-time education, they want it to be fun, they want to find purpose in this. And then Gen Zs, we're just starting to see, they're definitely all about the tech. They like infographics, they like videos, all of that. So each demographic has kind of a different learning style or how they want to learn. In addition, people learn differently, and I was actually in a seminar maybe about a year ago where we actually practiced all of this, and it was really fascinating. So we had these Lego sets we had to build, and some of them had visual like diagram like Legos usually are. Some of them had where somebody read you instructions on how to build this, and then we had one where it was like written out step by step but no pictures. I have never been so frustrated in my life. Apparently, I do not build things auditory. I almost like threw the Lego set away. So thinking about how do they want to learn it? Do they need to do it hands-on? A lot of nurses are hands-on learners. And you can kind of tell those people, they're the ones that are practicing the steps in their hand. So they're the ones that handle with care class that as I'm teaching or demonstrating it, they're doing the move as they're watching it. Some people really like videos, some people really like tip sheets and pictures, some people really like to learn information auditory. So thinking about that as well. I love Benner's stages of clinical competency. It's written more as a nurse, but I think it really reflects on all of it. So novices have minimal knowledge and they need rules. They need it black and white. On days 1 to 3, if they have diarrhea, we send a C. diff. Like they want it black and white. Novices, so this would be someone who's never been in a tech role before, need very close supervision. You should never, ever leave a novice person to do a task by themselves. So you really need to see 2 or 3 return demonstrations of every skill before you let them do anything. That means you go with them the first day and they do vitals on every single patient while you're watching. You're watching them drain a Foley. You're watching them take out an IV. You should never, ever let a novice do anything by themselves. So a good rule of thumb is really for the first half of the tech orientation, they should never be by themselves. You're always hanging out with them. Advanced beginners, and sometimes you will get kind of an advanced beginner if you have a person who's had that role before. With these people, it's really important that we're reviewing Centera guidelines. So what's different about this job versus another? So nursing home CNA versus PCT is a really big difference in terms of the scope. Nursing home people have not dealt with IV lines, not dealt with taking out IVs, have not dealt with Foleys as much, have never inserted Foleys as part of their role generally. So keeping in mind what's different about that role, what are they good at? And really a lot of nursing homes aren't doing vitals like we are. And then priority setting. So whereas in a nursing home, when I was a CNA there, you pretty much, unless somebody called, you started at one end and you just and changed all the patients and handed out waters and you just did it on a set schedule. Versus here where we have patients at varying levels of acuity. So that's going to be a big difference as you're seeing people transition from different practices. So the reason techs aren't part of this competency validation class or this preceptor class is that there's a lot of competency validation that can't be done by a tech. So there's parts of the competency tool that RNs do have to sign off, and you guys are more leaders, socializers, and trainers, not necessarily validation. But when we're talking about how we validate whether someone is good at something, we're talking about return demonstrations and direct observations for the most part. So that means on the competency tool, I don't want you just signing off things just to make me happy. I want you to think about whether that person actually knows the steps to do that task. Because again, what I'm trying to do as I'm precepting someone is to create someone who is ready for the role. So I know that this is not part of a tech role, but say this performs phlebotomy as per Nursing Reference Center. As you're validating as a direct observation, and you're signing them off after they are performing this competently. That means that they can go into a room, they can set it up on their own, they can put the holder on the phlebotomy needle, they can clean, they're putting on the tourniquet, they take off the tourniquet at the end, that it looks like what you would expect it to look like. So when you're signing someone off, what you're telling me as nursing professional development is that they know how to do that task. So unit-based tasks can be checked off by a peer. So this whole section of unit-based orientation, all of these can be checked off. And then there are parts that say shall be validated by a registered nurse. Those are things that you cannot check off. Those are things that the nurse will check off, or more likely the NPD. One thing we should start doing very early in their orientation is going over documentation. I'll try to help them create a patient list and they get a tech sheet on it. and we've got kind of a standard list that they can copy. But really getting into how do they document, how do they make sure all the documentation is complete. That needs to be happening from the very beginning of their orientation. They should be charting what they're doing. There really isn't time in the 3 or 4 weeks for them to spend a lot of time standing by the door, so it's important that we set those expectations that every day that you're on orientation that you're actually working with your preceptor and doing the task together. At the very end of the orientation, please make sure that you've signed all the areas. Generally, it's a nurse that signs the final thing, but on the signature lines, so anything you initial, you need to then, for your initial, have your full name and signature. So make sure that's signed and that the person has signed. Just make sure you look through all the signature areas to make sure that it's all correct. Here's a couple of preceptor models. So these are different ways to precept that may feel better to you than others. So married state is definitely a good one for novice, and that's where you work side by side and you do all your patients together. Single precepting, traditional model, this is people that are more experienced or towards the end of their orientation. They conduct care without direct supervision, but you check in on them, you double check that the work's right, and you make sure that they know the process. Again, for anybody who's a novice or anybody who's new to Sentara or anybody in their first couple of weeks, you should not be leaving them alone on tasks that they have not been deemed competent. Here's an interesting 10-minute model preceptor tool. And so basically at the beginning of your shift, deciding what is good for that person to learn. What have they not done? What do they need to work on today? Give feedback. And then asking how they're feeling, what problems they may have with a handover, what tasks they feel like they need to work on, what do they think is going to be the most difficult. And then at the end, kind of touching base again. What did they learn? What would be the next goals moving forward? And where do they feel like they're heading for their next orientation? It's also important that we kind of touch base from preceptor to preceptor. So this can happen informally or formally, but especially if someone's not where you think they should be, looping in your nursing professional development educator on where they are, and then they can loop in the next preceptor. So making sure that we're looking, how's it going? Are they where they should be? Do they still need? What's going well? And what would you recommend moving forward? All right, so to wrap up this, it's important that you learn about the orientee, that we have kind of this beginning discussion about what they know and what they don't, what their past experience is. Talking about that expectation and orientation plan. Generally, we want to start with the shadow shift so they kind of get a feel of the unit and where things are moving. But the shadow shift really can't be just standing back. They actually have to be moving. They need to make sure that they're in Epic, that they're starting to do some documentation, that they stick if they have a chance. And then we're adding patients as the progression moves forward. It's going to have to move pretty fast with the timeline. So what I have starting right now is a shadow shift or 2, and then adding, starting with 3 and 6 and 9 and then 12, and then the last 2 shifts need to be at the full patient assignment. Making sure we're kind of checking in at the beginning and the end, and your educator needs to be doing that as well, just checking in and then looping them in as you have concerns. And then really remembering that your role is introducing them to others, making sure that they're feeling welcomed and supported by the unit, that you're communicating effectively, that you're providing appropriate feedback, that you're role modeling appropriate behaviors, and that you're teaching the skills to the best of your ability.